Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this.
Hello, I'm Maggie Lavender, board-certified nurse practitioner who specializes in sleep medicine. Before my interview with Nicole, I wanted to inform you of the formation of Sleep Medicine Advanced Practice Providers Foundation. I am president and founder of this first-of-its-kind nonprofit dedicated to providing peer-led education and professional community for advanced practice providers in sleep medicine. The central mission of our foundation is to provide nurse practitioners and physician's assistants, as well as other APPs, with the expert APP for APP training and networking opportunities necessary to improve the diagnosis and management of complex sleep disorders. Advanced practice providers in sleep medicine, or any other providers who want to learn more about sleep medicine, are invited to visit the SMAP Foundation website to explore educational offerings, join our community, and register for upcoming resources. Please visit smapfoundation.org for more information. We would love to have you as part of our community. Thank you.
Welcome everybody to Airway Answers. I have Maggie Lavender here with me today. Maggie is a nurse practitioner that works in one of my favorite sleep offices in Texas, the Comprehensive Sleep Medicine Associates with Dr. Gerald Simmons, who we've interviewed a few times here. Thank you so much for joining us, Maggie.
Thank you for having me, Nicole. I'm so excited to be on here and share some knowledge.
Share some knowledge you will, because Maggie is a speaker for many pharmaceutical companies. In fact, right before we just started, you just finished another presentation. You're on a roll. You're so busy. I really thank you for your time. I know you're so busy with all the work that you do. And one topic of interest that's always been of interest to me is narcolepsy. So that's what we're going to talk about a lot today, because it's a very fascinating and often misunderstood condition. It's so much more than just being tired. I've learned from my experience hearing you lecture and learning about it through multiple patients that I have, that it's actually a neurological sleep disorder that's comorbid many times with our airway patients, our patients who have sleep apnea. And I've had so many cases where I'm working myofunctionally, so working on oral rest posture, oral functioning to help patients who might have sleep-related breathing disorders, when in fact there's also another condition, that condition of narcolepsy that's going on. And your office has helped to diagnose that. And if we're just treating the airway aspect and there's other neurological issues going on, we might not be helping these patients, or we might be extending airway treatments. Dentists might be using oral appliances and thinking it's not working when there's maybe another condition going on besides the airway component. So that's why I have you here today, is to talk about narcolepsy. We're going to go through from children through adults, the different underlying factors, what's going on, and the comorbidity rates with sleep disordered breathing. Before we get to that, I want to do your bio and talk all about you so people understand how amazing you are. All right, so let's go over all about Maggie. Maggie Lavender is a highly experienced nurse practitioner, right now working at the acclaimed sleep practice of Dr. Simmons, and you've been there for a while.
Almost 13 years consecutively. I had a little gap in the middle when we moved out of state and did internal medicine, but total practice time for nurse practitioners about 13 years, about 11 to 12 with Dr. Simmons.
You began your nursing career in a pediatric intensive care and burn unit, then expanded into a neuroscience intensive care unit at a level 1 trauma center in Houston. Later, Maggie completed her Master of Science in Nursing and Postmaster's Emergency Nurse Practitioner Certificate at the University of Texas Health Science Center. Her nurse practitioner career began in 2012 at CSMA, like we just talked about. And then over time, she has become a nationally recognized specialist and lecturer on the management of narcolepsy and other complex sleep conditions. And you are the nurse practitioner for many of my patients and family members as well. So I get to see you a lot, which is really great.
Yeah, I love it.
In this episode today, what we're going to do is we will unpack what narcolepsy really is, how it's diagnosed, what treatments are available, and for all of my dental and airway professionals listening, how you can play a role in identifying early warning signs in your patients. So, whether you're a parent concerned about your child's sleepiness, or a clinician wanting to deepen your own understanding of the sleep, airway, and neurological connections, we are going to answer a lot of those questions. So let's talk about you personally, how you got interested in sleep disorders, not specifically narcolepsy, but how that became a pathway for you, but also sleep in general.
So, as you had stated, my practice as nursing started in pediatric ICU. And then I moved, that was in Louisiana. And then I moved to Texas because my dream really started way before that. Ever since I was 4 years old, I knew I was going to be a nurse. I was putting band aids on my babies, and I always wanted just to take away the pain and help. And so I knew I was going to be a nurse, and I went into pediatric ICU. But I knew my bigger dream was to get into anesthesia because I thought that was the way to help patients with pain and take it all away from them. So I had to get into a bigger facility, and level 1 trauma was the way to go. So I moved to Texas and got in with a level 1 trauma neuro ICU unit and loved it. I went from floor nurse to charge nurse and was very young in the field, but I was charge nurse over 35 beds and just fell in love with it. And I had all of my grad school paperwork ready, and I was sending in my paperwork the next week for anesthesia school for a nurse anesthetist. And I was at the bedside with one of my internists, and they were like, "What are you doing?" And I was like, "I'm going to grad school. I don't know what you're talking about." He was like, "No, bigger picture. What are you doing? Like you have more to offer than putting patients to sleep. And you're really good with patient education and the whole 9 yards." And so it was the first time someone really brought that to my attention. And it was in that moment that I realized I do have the ability to do more than take a person's pain away, that I can do that in many different aspects. So from that night, I shredded my grad school paperwork and filled out new paperwork and went into nurse practitioner school. And I never looked back. I was concerned whenever I would get out of nurse practitioner school that with all of my ICU and trauma experience that maybe I'm going to get a little bored. So I did a backup of emergency room nurse practitioner just in case I wanted a little more trauma in my life. So then that once I graduated and passed boards, I was looking for a neurology position because that was my background of nursing and that's what I loved. And so that brought me to Dr. Simmons' practice of comprehensive sleep medicine, because he's neurology, sleep, and epilepsy. So I was like, yes, let's do a lot of neurology and a lot of epilepsy and maybe a little sleep on this side. Little did I know that I fell in love with sleep, and we do a lot of sleep. Full body, everything from birth to death, everything from breathing issues, narcolepsy, hypersomnias, parasomnias, bruxing, seizures in your sleep, the whole 9 yards. So that's where I found my passion and my love for sleep medicine. And by taking care of those patients, I realized that there's more to the story. There's so many of us that are struggling with excessive daytime sleepiness, or fancy term, hypersomnia. And there was more I could do to help them. And that's how I found my passion of sitting and educating patients and talking with them and really understanding their symptoms, where I fell in love with hypersomnia and narcolepsy. So the sleep bug bit me, if you would say.
Wow, and you have so many interests. That is
Mhm.
quite a background, so much
Mhm.
experience. That's amazing. And I feel like a lot of us who go into that sleep pathway get really sucked in because we all sleep, right? With something we all have. And to just hear the different types of dysfunctions or disorders people can
Mhm.
have around sleep, which is such a basic human need, is really just crazy to learn about all these things. And I would love for you to explain exactly what is narcolepsy, because I think a lot of people are afraid of that word. And
Correct.
probably the layman would say, oh, it's this thing where you just get tired and you just fall asleep and collapse on the
Mhm.
floor. And
Mhm.
that's not exactly what it is. So, can you talk about the different types of narcolepsy?
Correct. So narcolepsy falls into the category of a hypersomnia disorder or a central hypersomnia disorder. Hypersomnia, like I said earlier, is just a big fancy word for someone who's really sleepy. Hypersomnolence. So somnolence is sleepy, hyper is a lot of sleepy. So when you have to fully understand what is causing the patient's excess sleepiness during the day, and the media portrays narcolepsy as, we just fall out and, fall on the floor and are sleeping inappropriately for all these different things. That does happen, but that is not majority of our narcolepsy cases. So by definition, narcolepsy is a disruption or a disorganization of your sleep and wake cycle. So everyone thinks of excessive daytime sleepiness and narcolepsy being only a daytime disorder. It's actually a 24/7 day and night disorder because it's disruption of your sleep and wake cycles. So that brings you into the symptoms of what a patient with narcolepsy has. Well, number one is daytime sleepiness, excessive daytime sleepiness. You cannot have narcolepsy without being sleepy. So that's a given. Okay. And then you have disrupted nighttime sleep. You have sleep paralysis. You have hypnopompic and hypnagogic hallucinations. Okay. And then for one of the narcolepsy types, you have cataplexy. You don't have to have all of those symptoms. You have to have, for sure, excessive daytime sleepiness. And then depending on where you are in the disease state, you can have the others. So to put it into English terms, because I know the medical jargon gets a little complicated sometimes, but I explain it to my patients and I explain it in many presentations, is think of a light switch on and off, okay? A non-narcolepsy patient will turn their switch on in the morning and we're up. We can function through the day, maybe a nap here or there if we didn't get enough sleep, but for the most part, we're up, we're awake. And then when it's time to go to bed, we flip our switch, it's nighttime, we go to sleep. A narcolepsy patient switch is going on and off all day long. So when they're trying to be awake, their body's fighting sleep. And when they're trying to sleep, their body's fighting to try to be awake. Again, the disorganization of the sleep and wake cycles due to the different neurotransmitters that control us being awake or asleep. And that's where it comes into how different medication classes work, because it acts on different neurotransmitters. So to truly understand narcolepsy as being a 24/7 disorder helps patients further understand that, hey, maybe I really do have that because I have all these other symptoms. And more times than not, honestly, my patient will come in and complain of insomnia. I have difficulty staying asleep. I keep waking up over and over. And they get referred to me after they've been to many doctors because they've been put on multiple sleeping pills to help them sleep. And guess what? It works for a little bit and then they're back with the same problem. And they keep thinking, well, you're tired because you keep waking up all night long and you're not getting good quality sleep. That's true, but there's more to the story. And that disrupted nighttime sleep is a classic situation in a narcolepsy patient.
Wow. Okay. I have so many thoughts and questions. So this is really interesting because I learned through one of my patients about the disrupted nighttime sleep with narcolepsy because I just thought you're just tired all day, but I didn't realize that you're awake a lot of the night, not just insomnia, but what I learned from my patient who actually was diagnosed through your office and was recommended for jaw surgery for sleep apnea and did have physical characteristics in the mouth that would signify an airway issue. So he had a combination of, but Dr. Simmons made it clear also that you might treat your airway issue, but you might not feel good because you also have narcolepsy. So
Well,
from
you'll
this,
feel better, but define better, and what you think is better because you've been bad for so long, it truly is better, but is it the best that you can be? And that's where we come in to try to peel apart those symptoms for you.
right, and undergoing a major surgery, a jaw surgery, or other orthodontic treatments, it's good to sort everything out. And through my patient, I learned that he was awake a lot of the night through dreams or excessive vivid dreams, maybe waking a lot. So can we talk about there's type 1 and type 2 narcolepsy? Is that correct?
Correct.
Okay.
So let's first get to the understanding that narcolepsy truly is considered a rare disease. So it's about 1 in 2,000 cases. So that's about 200,000 individuals that are diagnosed. Thought is believed that about 50% is undiagnosed. So the number is more than that. But right now it's rare disease. About 1 in 2,000, 200,000 cases of narcolepsy have been diagnosed and into treatment process. But there are two types. There is type 1 and type 2. Type 1 is also called narcolepsy with cataplexy, or type 1. And then narcolepsy type 2 is narcolepsy without cataplexy. So as I said earlier, the 5 classic symptoms of narcolepsy is, of course, excessive daytime sleepiness, disrupted nighttime sleep, sleep paralysis, hypnopompic and hypnagogic hallucinations, and we'll define all these later. And then finally, cataplexy. So in order to have cataplexy, that's the abrupt onset of muscle weakness whenever, you're awake doing things. And it's not just, my nerves hurt or my pain is causing my body to feel heavy. This is abrupt and then it goes away. It's often brought on by a heavy emotional state. So it's a very specific symptom and it often gets missed because we don't ask the right questions to define it, because no patient's going to come to you and say, hey, I have cataplexy. No, they're going to say, hey, I dropped this paper that I don't really know why I dropped it. I had a good grip on it. Or when I laugh, I kind of have to hold on to for support. My legs don't feel like they can hold me. Or I laugh and this side of my face feels a little numb, or my eyelid droops, or my head is just, I can't hold it up. So you as providers, we really have to be specific and break down what these symptoms are and help patients understand it. And oftentimes, originally, when I ask the patient, they're like, no, I don't have that. But I've set the seed. And then they go home and they're like, wait, no, I really do have what she was talking about. And it happens only in this emotional state, or only when I'm really exhausted, that I just feel like my body is 1,000,000 pounds and I cannot hold it up. But it's very brief. So that's the classic symptom that differentiates narcolepsy type 1 from narcolepsy type 2.
Okay, so narcolepsy type 1, they have the same symptoms, except type 1 has a
That's
cataplexy.
the addition to cataplexy, correct?
And the cataplexy is really interesting to me. So it's just a sudden loss of muscle control. It's muscle weakness.
Correct.
So
Muscle weakness, numbness, or tingling.
weakness, numbness, or tingling. And it sounds like it could be part of the body, like just the face, the arm.
It could be part of the body is just in the head. It could be part of the body is just on one side, or it could be full blown. Your body collapses. You can't hold yourself up.
Wow. Okay. I didn't realize that it could be mild or,
Yeah, we
constrained.
don't really use the term as far as cataplexy is mild, it's moderate, severe. It's just there's an elaborate, and some patients will tell us, in this type scenario, this side of my face happens, or if I'm really upset or angry, then I can't hold my body up. So you can have a spectrum in one patient, or you can have just a little, or the full blown, full body.
Okay. And it's interesting to know that some patients might not be aware of that. And you plant the seed and then they notice later, because it sounds like it would be so profound that someone would think like, what's wrong with me? My arm falls or whatever. But people
They've
might not.
been living with it for so long, it's just part of them.
Wow. This actually makes me think one of the conferences I went to, a lady spoke about her own experience and she wrote a book. I'm forgetting her name. It was really fascinating. She went on stage and talked about her whole condition. She actually started crying, and I think a lot of people in the audience were crying also because of how devastating this was just to her whole life until she got the diagnosis and it was missed. But the person who discovered the cataplexy component was her physical therapist.
Correct. This is Julie Flygar.
Oh,
Yes. So Julie Flygar is a world-renowned patient advocate for patients with narcolepsy. And yes, her story was she was in law school and she was just tired, and everything was related to this point in life, and that's whatever often happens. I have kids, I'm up all the time, I have busy schedules, my job is stressful. We adapt and we label it to something else, and it often gets missed. And that's exactly what happened to Julie. And she was actually having cataplexy episodes, but again, related it to something else because it was her normal. And it wasn't until she started realizing that, like, she's at a concert with her friends that she's been looking forward to for forever, and she's passed out, not because she's been drinking, but she's sound asleep. And so she kind of put the pieces together. And I think it was either her physical therapist or her orthopedist that after one of her races or something, they found an issue with her knee. It wasn't really a knee problem. It was her cataplexy event that she couldn't hold her body up. And that's how he brought up, hey, maybe you should go to a sleep specialist and look into this. And that was the first time anyone used those specific terms with her. And she got a diagnosis, and she is now living a very productive, regular, normal life just with proper treatment.
wow. Okay, we're going to get to the treatment at 1.2. Back to the type 1, type 2. So now I understand the difference. Type 1 just has added cataplexy. Type 2 has the other symptoms, the excessive daytime sleepiness, the nighttime sleep disturbance, right? That was number 2. Disrupted nighttime sleep, the sleep paralysis, and also the hypnagogic hallucinations. How do you say it?
Hypnopompic. So let's explain it. So sleep paralysis, how I explain it to my patients is you're asleep and you know you're asleep, okay? But then you wake up and you know you're awake because you can look around the room, but you can't move your body. It's an actual paralysis state. And how it really full circle makes sense is when we go into REM sleep, whether it's narcolepsy or not, when we go into REM sleep, our body becomes paralyzed. That's when we have our most active dreams. And if we were not paralyzed, we would be doing some crazy things. And there are those patients that do those things. That's a whole nother disorder. But for the most part, in the general population, we're actively dreaming in REM sleep and we're not moving our body. We're paralyzed. So when you think about a narcolepsy patient, narcolepsy is, again, the disruption of sleep and wake. So whenever the patient is awake, their body is trying to go into that sleep state and that REM sleep state, and they have that part of that paralysis, but yet they're awake. So their body is acting as if it's in that REM sleep state, but they're awake. So that's where the paralysis comes from. So it's the transition from sleep to wake. And then
that's always abnormal because, well, I've had that before a few times. I know
well,
you
that's
said
the
a handful
thing.
of
Out
times.
of pure exhaustion or different states, a non-narcolepsy patient can have it here or there in their life. But narcolepsy is pretty profound. They have it more often than the common person who just is sleep exhausted because they pulled, 2 all-nighter sleep, working for finals or whatever it may be. So the non-narcolepsy patient may have it a couple of times in their life, but narcolepsy patients have it more consistent.
And when you say more consistent, how often does that maybe
It just depends. I mean, some have it every couple months, some have it multiple times a week, but it's very scary for patients. Like whenever they don't want to automatically tell you about it until you question because they're like, well, I'm crazy. Nobody else talks about being, paralyzed in their sleep. So they don't often bring it up. But when you ask them and, kind of say this is a pretty common finding in patients with hypersomnia or narcolepsy, they're like, yeah, that happens to me, a couple of times a week, or yeah, I had that a lot as a kid and then it kind of lessened and then now I see it more. So it is a symptom that is more than just once or 2 times in your life.
when I've had that symptom and other people, I'm sure have felt this maybe at some point, but it's like you want to wake up, but you can't move your body to wake up. Like, so you're like,
And it's
okay,
not like your body is a million pounds. It's not like there's something physically holding you down. You just you don't control your body. Like you just can't move. So it is a very scary
yeah.
thought. In the world we live in, your first reaction is not narcolepsy. Your first reaction is, oh my God, did I have a stroke? Like what's wrong with me? Like something is wrong.
You're like, I could not move and I was trying to move and I couldn't move.
Yeah, and they're trying to yell out and they can't yell out. There's no sound or anything coming.
Yes. Oh, it's scary. So the sleep paralysis and then the hypnagogic.
Hypnagogic and hypnopompic hallucinations.
Okay.
So there's a little trick that I like to play on words to help me remember all these really hard words to learn. So the idea of these hallucinations, again, it's back into the dream state and sleep state. You're going in and out of these sleep states. So it is when you are awake going to sleep or you are asleep trying to wake up. So it's in your sleep transition phases. And it's auditory hallucinations or visual hallucinations typically. Some patients will talk about olfactory, where they smell different things that aren't really there, but typically it's auditory and visual. And the understanding of which one we're talking about is either transition awake to asleep or asleep to awake. So you're going to go to sleep, so that's your hypnagogic, and you're going to pop out of sleep, which is your pompic. So that's my little shortcut to explain it.
I better never forget that now. That is so great. Hypnagogic, when you're going to sleep, hypnopompic, as you're waking up, you have this type of hallucination. Can you talk a little bit more about what that's like?
Yes. So the obvious, as I explain to my patients, is, the obvious one. If you're dreaming about the purple elephant isn't in the room staring at you, but it's not typically like that. These are a little more eerie, a little more frightening, a little more scary. There's spiders crawling on you. There's a visual in the corner of your bed, and it's like you can't really make out what it is, but it's this eerie little creature. So it gives you this uneasy type feeling. I kind of describe it as also, because not every patient can say, yeah, I see the thing in the room with me. They hear the train, they hear the loud pop. But another way that I explain it is, in a non-narcolepsy patient, we are typically an active participant in our dreams. So like the dreams are happening and we're actively involved in the dreams. Narcolepsy patients tend to describe it as the dream is happening and they're kind of like overlooking it. So they're not that active participant. So that's where those visuals come into the room and they're hearing these things like they're there and they know they're there. They can see and hear everything, but they're not actively involved in it. So just kind of understanding how to talk with the patient and see what their symptoms are, because not everyone has the same presentation.
And I can imagine that's really scary if you don't know what's going on. And let me just say, I've had that too. I've had that before. How common is that for someone who does not have narcolepsy?
Again, the same thing as sleep paralysis. Out of a pure exhaustion state, you've been up a couple times or may have had some alcohol involved, those type of things. It can happen to a non-narcolepsy patient, but it is not as frequent as a narcolepsy patient. Like sometimes these patients, this is a nightly occurrence for them, hence why they keep having these disrupted sleep disturbances.
That's scary. It's scary. I know what it feels like. And for me, when it's happened, because I know what's happening, I just tell myself, look, you're having one of those dream hallucinations. It's not real. And then for me, when it's happened, I talk myself through it until I wake up. And
Correct.
I'm usually there's like a figure standing there looking at me like a
They're
scary.
normally not pleasant hallucinations.
No, it's like a scary.
No one's going to complain about the little puppy dog in the room. And
Right?
there's actually, my bad for not remembering the author's name, but she actually wrote some books that help explain narcolepsy and things to pediatrics and trying to understand. And one of them is the puppy dog in the room. And so it's typically not these warm and fuzzy happy things that are happening. It's these scarier things. And patients don't want to tell you about them because they don't want to be labeled as psychotic. And especially a kid is not going to tell you they're seeing these things in their room. So it's our job to question and ask these specific details.
Okay, so before we talk about pediatrics and the occurrence of this, what is going on in the body? So what causes narcolepsy? Is it genetic, autoimmune, environmental?
So the correct answer is your guess is as good as mine and a combination of all of it. We don't truly know. We know that there is a genetic component because particularly in type 1 narcolepsy, there's a loss of the orexin neurotransmitter or neuropeptide. So that is the genetic component. We can find that out. I mean, we're not volunteering to go, do spinal taps on patients and look at their cerebral spinal fluid to get a measurement of orexin, but we know in narcolepsy type 1, there is a huge diminished amount of orexin, and that is that genetic component. But the key question is, well, why did that happen? You weren't born with it. So we believe that there's an environmental factor, or what I like to say is an environmental hit that has triggered the immune system that then caused this genetic factor to happen, and you start losing the orexin. So when you look back at history, you can often, if we were able to truly do this, but we can look back at history and see that there typically was some type of environmental hit, a major illness or something like that, that then a little bit time followed, then that's when they started developing the symptoms of narcolepsy. You can look back to the Spanish flu, you can look back, years to date, the H1N1, all those things, they had higher instances of a narcolepsy spike within a certain months following that. Typically, we see higher incidence of narcolepsy in the spring months following the respiratory season in the fall and the winter. So it's most of the time of a respiratory hit that really hits your immune system, and then that's your environmental hit. But then when you get to the mixture of both, that's where you kind of get your narcolepsy type 2s. We don't really know. There is some diminishment of orexin, but it's not as low as narcolepsy type 1, but it's a combination of all of the above. And then often you truly see in a patient with narcolepsy, not all the time, but often you see other autoimmune complexities or clusters. We say that there are other autoimmune diagnoses that we eventually follow along with.
Wow. So type 2 also has diminished orexin neurotransmitter as well,
It's
but
a
not as
very
much.
limited amount.
Okay, but all type 1 with the cataplexy will have the orexin neurotransmitter deficiency.
Yes, like there's pretty much bare minimum to none of left.
And orexin is a neurotransmitter that helps
It's our
with
wakeful agent.
weight. Okay, and then that's interesting, this autoimmune component or this environmental hit that causes immune or autoimmune issue. So could narcolepsy be diagnosed with blood tests, or you talked about a spinal tap?
So yes and no. So narcolepsy, by definition, as it is now, there's research and stuff that's saying that maybe we need to change the parameters of how we test. Narcolepsy is diagnosed by an overnight polysomnogram where you sleep in the sleep lab and the doctor is able to see what is going on in your nighttime sleep. We rule out sleep apnea issues, we rule out restless leg issues, we rule out anything that is causing disturbances in your sleep that can be treated. And then you spend the following day and you take a series of naps, 4 to 5 naps, about 2 hours apart. And we put you in a sleeping scenario and see how quickly you go to sleep. Do you go to sleep and what stage of sleep you go into? Depending on those findings, we look at, are you falling asleep by definition under 8 minutes? Are you going into REM sleep on any of those sleep cycles? And if it's under 8 minutes and at least 2 or more of the napping sessions are in REM sleep, then you have a definition of narcolepsy, okay? And Dr. Simmons and I like to say, who was God that said you fall asleep at 8 minutes and you have it, and you fall asleep at 8.4 minutes and you don't? You got to look at the whole spectrum of what's going on. But that's clinically how we test it, also with the rest of the storyline and the pictures of, do you have the rest of the pentat of symptoms?
So real quick clarification on the 8 minutes. So it's marked by excessive sleepiness because you can fall asleep quickly under 8 minutes.
Quickly, because typically we should not fall asleep under 20, which is where the naps are timed out at. But if you fall asleep under like between 15 and 20, you have some hypersomnia, but you don't quite meet the qualifications for narcolepsy. But the defining feature of narcolepsy is you went into REM sleep on those naps.
Okay, so you fall asleep in under 8 minutes, but you go into REM sleep in under
Correct.
8 minutes. So
Correct.
it's also a disorder of sleep-wake in general, but also the hierarchy, or what's the word I'm thinking of? The sleep
Progression of sleep
cycles,
staging.
the sleep stages, right?
Correct.
It's
So,
not in the
so
correct order.
kind of understand, let's give a little bit background information. So let's talk about a non-narcolepsy patient. So we have different stages of sleep. We have stage 1, which is very light sleep. Stage 2, it's a little bit deeper. Stage 3 is our very deep mental restorative sleep. It's our slow wave sleep. And then you have old textbooks say stage 4, but that's your REM sleep. That's your deep, deep, mostly vivid dream state sleep. That's when we go into that paralysis state. It is your muscle restoration. So it's your physical restoration. Okay. When you have a non-narcolepsy patient, we typically will cycle through those sleep stages overnight every 90 minutes. So at the beginning of the night, your lighter phases, stage 1, 2, are longer and REM is shorter. And then with the next cycle, stage 1 and 2 shorten and 3 and REM get longer. And then that's how it goes. By the end of the night, you're getting really long REM phases and then really short light sleep phases. That's why everyone says, by morning, I'm just such in deep sleep. Like that's the best sleep because you're getting into those major restorative phases. In a narcolepsy patient, there is no organization of those sleep stages. It's all over the place. They often go into REM pretty quickly, but the REM stages are very brief. And so when you look at what's called a hypnogram, it's the one-page visual aid of a sleep study where it kind of puts everything together. You can see very disorganized sleep staging whenever you look at a narcolepsy patient. And it is not that a narcolepsy patient compared to a non-narcolepsy patient sleeps more. The total time is pretty much the same. It's just that the disorganization is there and they're having more brief episodes of REM versus more consolidated sleep cycles of REM.
Okay, that's very interesting.
Under 8 minutes with REM is your narcolepsy, but then it could be under 8 minutes with no REM. That's not narcolepsy. That's a hypersomnia. We'll get into that later.
What is idiopathic hypersomnolence?
So idiopathic hypersomnolence is, I like to use, again, very basic language, is you look like narcolepsy, you smell like narcolepsy, but you're not narcolepsy, okay? So it's your very sleepy patient, but yet I don't have a reason to explain why you're sleepy, okay? So I've ruled out all of the nighttime issues. I've ruled out the narcolepsy because you're not going into REM on any of those naps, but you are excessively tired and you are falling asleep faster than you should on those napping sessions, but you're not going into REM, okay? And there is a classic difference of a narcolepsy and an idiopathic hypersomnia patient, okay? So an idiopathic hypersomnia patient, of course, has excessive daytime sleepiness. They have unrefreshing sleep. So a narcolepsy patient, often one of their treatments is schedule a nap in the middle of the day or whatever time is appropriate for them. Not long, but a quick nap. They feel great when they wake up from their nap and it will sustain them for a while. An idiopathic hypersomnia patient is, again, they need prolonged sleep states. They have unrefreshing sleep and they do not feel better after a nap. It doesn't help them, okay? So that's a big key factor. And a narcolepsy patient, they just are tired all the time, but they can get up and function, and then they have these inappropriate sleep spells during the day. An idiopathic hypersomnia patient, these are your patients that don't function in the morning. It's called sleep inertia. They are slow-mo. Like, don't talk to them before they get to the coffee pot, and still 2-3 hours later, they're still barely awake. These are your long sleep inertia patients who the excessive daytime sleepiness overcomes their life, technically. These are just really, really sleepy patients. So
But
it's
they
not
don't
more
meet
severe or narcolepsy is more severe. It's just a different presentation.
And they don't meet the criteria for narcolepsy because they're not going into a REM sleep stage right away.
Correct.
What is lucid dreaming? Does that follow any of the signs?
It kind of does. It gets intermixed with that regard. So lucid dreaming, again, is where I told you that you're kind of active participating in your dream. So when you look at a narcolepsy patient who's going in and out of these sleep states and they're going into REM pretty quickly. Well, in REM, we have vivid active dreams, right? So if you're sitting down and as soon as they sit down, they're going into REM, they're in and out of that dream state. So their dreams kind of feel like they're in reality, like they're kind of taking actions of what's going into the room. They can control them in their dream, and then they're up briefly. And then they kind of like go back into a dream state. So it's not that they can control their dreams, but they may have a little participation part in there that it's kind of interactive of what's happening, okay? In a narcolepsy patient, you typically are going to have about 7 of these a month, whereas a non-narcolepsy patient, you're going to have less than 2, like 1 to 2 a month. So there is a big difference of these lucid dreams. We really don't use that term, but if you really want to break it down, that's what it means.
Okay, that makes sense. So how common is narcolepsy and what ages does it affect?
So narcolepsy is considered a rare disease. It's 1 in 2,000, so about 200,000 patients will have it. But we know that more than 50% are not diagnosed. And why is that? Well, we can get into a whole spill of misdiagnosis, missed diagnosis, and what other things it gets labeled as and missed through the line. But narcolepsy truly is a pediatric disorder. We typically don't find it until later in life. So the typical age of narcolepsy when it begins is anywhere from age 7 to 25 years old. It's often detected between 10 and 30 years. But from the moment of symptoms to diagnosis, it's 8 to 22 years. So it's a long process. And I'll never forget, I had a patient who was 77, and I was the first one to diagnose him with narcolepsy. And upon questioning, he had it back since he was a teenager. And
He
it got
remembers, yeah, the
yeah,
symptoms.
he was a 𝐃𝐈𝐒𝐂𝐋𝐀 type 1,
Oh,
and he
wow.
had it for his whole life. And if you're not involved in it and you're not, really understanding the patient's senses, you're like, okay, it takes forever to diagnose. But when you're understanding what this disease state really does to a person and how they miss out on life because of their symptoms, 8 to 22 years, that's an entire life. That's an entire childhood. That's growing up. That's marriage. That's kids. Like you slept through all of that. And so they miss out a lot on life, for sure.
Yeah, and I know your office asks really detailed questions
Mhm.
from the intake questionnaire to the actual appointment, where your office doesn't really miss these things, but I can see how somebody who does not go to a specialist, is maybe
Mhm.
asking their general practitioner, doctor, or whatever, it
Yes.
could get missed. And
Mhm.
I didn't know that children can have it. I thought it's something that develops way later in life, but age 7, it could begin at age
It
7.
begin as early. No, that's not every case, but it could begin as early as age 7. And again, we really have to be better as providers. If you have that patient who's coming in that they're tired, or you have that mom that's coming in, and because kids and adults present differently, but you have that mom, they're like, my kid's not keeping up with the peer. We got rid of naps a long time ago, and my kid's napping again. Like they can't stay awake after school. They're choosing to sleep over, go and play with their friends. That's not normal for kids. So trust your gut, trust your intuition, and really bring these symptoms to your providers. And as providers, we need to do a better job of not just going, oh, they're a kid, oh, they're growing, oh, they need, don't need as many late night sports, and they need more sleep time. Really, really ask good questions and try to figure out what is going on, and don't just rule these kids out, and adults for that matter.
And do sometimes in children, they sleep excessively in their nighttime sleep? So not just maybe being tired or more sluggish during the
Mhm.
day, but does a child who might need like 10 hours of sleep, let's say like
Yeah.
a 11-year-old, would they maybe sleep like 12, 13, 14 hours, like a full night, and you have to wake them up
And they're
most of
still
the
exhausted and need a nap. Yeah,
Yes,
absolutely.
that's
Adults do that too.
yeah,
Mhm.
interesting. So, can it be mistaken, or is it often mistaken for other disorders like anxiety, ADHD,
Yeah.
depression, or what other things in children?
So that's kind of what goes into the role of why it takes so long to get this diagnosed. So oftentimes we'll get a patient in our office that have been to the psychiatrist, the primary care, you name it, they've been there, and they have been put on antidepressant medications because, oh, you're just depressed. That's why you don't want to get out of bed. That's why you lack motivation to go do anything. Kids are labeled as ADD and ADHD because they can't concentrate. And so the brain mechanism of to try to keep you awake is to become hyperactive, right? A ADD, ADHD brain, majority of the time, is a poor sleep brain. And so that is a diagnosis that gets missed, not missed altogether, but wrong diagnosis. And then how do we treat those patients? Put them on stimulants. Well, guess what? Then we mask some of the symptoms of the exhaustion, and everyone thinks the kid is better. But then the medicine's not going to work, and we're back to the same one. And oh, we need to switch the medicine. And so they often getting labeled by all these things. I have patients in my office that when I finally give them the diagnosis, they start to cry, and it's the happiest tears that they've ever shed because they're like, I'm not lazy. You mean like I'm not this person that everyone has called me? Like there's a reason of why I can't function, and there's a reason of why I choose to sleep instead of going to my kid's soccer game. And it breaks my heart because they haven't been heard, and that's the key. You can hear them, but we're not truly understanding what the patient is coming from, and they go through years of poor diagnosis. the doctors didn't listen to them. They've been put on a slew of medicines that their body never needed, and it masked the symptoms for us to miss it.
Yes. And I had an adult patient who was practically suicidal. His marriage was collapsing. He could not function. He could barely work. He could barely drive to work, but he was an airway patient that was not diagnosed until later with the narcolepsy component. And
that's where it gets missed. I mean, airway patients are still hard to get, it's hard to properly diagnose. But if you can get them diagnosed and we treat them or partially treat them, that I've seen them from other practices, and the patient's tired, they're like, well, lose some weight, get some more sleep, right? And it gets blown off. But if you truly know you have an airway patient, you are properly treating their airway, and you know all of their airway issues and obstructions are fixed. There's no periodic limb movements of sleep that's adding to the fragmentation of their sleep. Their sleep looks as perfect as you can get it, and this patient is still tired. We got to do some further testing. Don't overlook these patients because they have a hypersomnia disorder that we got to figure out why.
let's get deep into this narcolepsy, sleep disorder, breathing, comorbidity. Let's talk about that. What is the comorbidity between those two disorders, like a sleep apnea and narcolepsy?
Typically see it's around the 55% range of when they're joined, I should say. Okay. So you can see some reports say 25-ish, and then some go up to 55. So 35 to 55. Okay, let's put it in there. So there is a big crossover, but I still feel that we're missing the mark because people are just home testing these patients and giving them an airway diagnosis, and here's your CPAP shipped to you, and then hands down, they're done. And they go back to primary care, not to throw primary under the bus, y'all are great, but they go back to primary care and they're like, I'm so just tired. Okay, so let's run some labs. Let's rule out, anemias or thyroids or anything like that. And, maybe there is psychiatry, you're speaking with them because you're dealing with some anxieties or some depressions, and they're like, oh, here's just a little pill, that'll help boost you a little bit during the day. And it's just getting missed, but they're interconnected. And so before we just throw things at our patient, we truly need to hear the story and know that there is a link between sleep apnea and narcolepsy. And these patients often have both. And we should do our proper justice to our patient to get into further testing to rule it out.
There was something I remember Dr. Simmons said was like in the 80 or 85% range. I don't know. A patient with narcolepsy, is there numbers for this? If you have narcolepsy, how likely are you to have sleep apnea? And then on the contrary, if someone has sleep apnea, what is their likelihood of having narcolepsy?
And that's where the mixed reports come from. And I think maybe you may be remembering the numbers from our practice, because again, we see a lot of the more complicated cases that we've gotten the patients who've been to 10 plus providers before they've gotten to us. So our numbers are a little more skewed. Typically we are in that 80th% range because of the complexity of our patients. But in the general practice and population, you're in that 25 to 55% range.
Wow. That's crazy when you have such a tailored audience or such a tailored clientele, then you're going to really see those comorbidities so much more because you're looking for it.
And you have to it's important as providers in our practice that we still have to remember this is a rare disease. Even though we see it on a daily basis and we're treating it on a daily basis, it's not that common in the general population. So we do it daily, but it's not daily for everyone else. And so you have to kind of continue to ground yourself with that.
Yeah, that's a good way to think of it. And I believe from some of your questionnaires that your office has shared and has allowed other practitioners to use these questions on their own intake forms. I use a lot of your questions, and hey, I'm a speech therapist. What does that have to do with narcolepsy? Well, I also treat myofunctional disorders, right? And a lot of the myofunctional disordered patients have an airway problem. And then we find a lot of those have a sleep problem and they're tired. And so asking those additional questions has really helped me to broaden my referral base, where I'm referring patients out, because I'm seeing a lot more problems than I would have had I not asked. Even you said periodic limb movement. I'm asking patients about restless leg syndrome. I'm not saying do you have restless leg, but asking them questions that align with these areas, finding, wow, a lot of these patients have more than just what they came for. Unfortunately.
This is off topic, but I had a patient today that he had very, very severe periodic limb movements of sleep on his sleep study. And he was like, I'm not aware that I'm moving. He's like, I don't report any restlessness. I don't have the creepy crawly sensation. And he's in the office the entire time. His feet are moving nonstop. And I brought it to his attention. I was like, well, you may not report restless leg symptoms, but your feet have not stopped since I came in there. He goes, oh, this is all the time. And I was like, That's
just
it.
normal.
You may not get the pain sensation or the creepy crawlies, but that's what we're dealing with, and that's what's compounding, the movements in your sleep. So yeah, patients just don't know what to call it, and it just becomes part of their norm.
And and nobody knows until we ask and we start questioning, opening up extra cans of worms. So does the airway obstruction or poor sleep quality exacerbate the narcolepsy symptoms in a patient with sleep disordered breathing? Is it going to potentially make them more tired so then symptoms are worse?
So it's a complicated answer. Okay. So you can see the blurred line that if you don't get good nighttime sleep, your daytime symptoms are going to suffer. Okay. But when you look at the complexity of both diseases, you have to look at the age of the patient. What other comorbidities are they having? What stress are they under? What other medications are they taking? What is their natural innate internal clock? Okay. They may be trying to have a sleep clock of what the world says. You go to bed at 9 and you wake up at 6. Well, guess what? Their internal clock is midnight to 8. So they're struggling in the morning, but that's not when their body's ready to be awake. So there's a lot of questions you have to ask. But the basis is, can untreated sleep apnea lead to symptoms representative of possible narcolepsies or hypersomnias? Yes, because if you don't sleep well, your performance during the day is going to be even worse, right? But in a narcolepsy patient, we can't just say, oh, you're tired during the day, so you have narcolepsy. You got to look at the whole comprehensive patient.
Okay, so could years of having an airway issue, say from childhood, from birth, like having apnea or any form of sleep disorder breathing, so you're just excessively tired, could that trigger someone to go into REM sleep really quickly?
It can, but again, you have to peel it apart because I have patients that I have diagnosed with very mild sleep apneas or, without getting complex in this talk, there's different ways to look at a diagnosis of sleep apnea as different roles you're looking at. And so when you break down the different roles, you can have a patient that has mild sleep apnea on one of the roles and more severe on the other. In our practice, we treat both, right? But yes, they can cause you to be sleep deprived and cause you to fall into REM sleep very briefly when you're not supposed to. So it can mimic it. But you really need to treat the airway. You need to treat the nighttime problem first and see what you're left with because they may first start to look like a narcolepsy patient. But when you treat that and get their body back in sync and get their body back into a rhythm and you test later on, they may not be testing as a narcolepsy patient.
So that's really important. And I think a lot of airway patients are misdiagnosed, as we know, or not diagnosed, not even just misdiagnosed, maybe misdiagnosed as things fine or missed completely. And
And we know that the daytime napping test, the MSLT that we use for diagnosis of narcolepsy, we know it has a test retest reliability. So we have some patients that I'm like, darn, it has to be narcolepsy and they just don't do it. And it may take me 2, 3, 4, 5 times to get the proper test on them because they have testing anxiety, they have performance anxiety, or they're not in their normal natural environment. So the fan in the room is making a little buzz that they're not used to, or whatever it is, causing them not to go into their natural sleep state on those naps. So trust your gut, continue to ask questions, and don't be afraid to retest.
yeah. And if a patient has narcolepsy, but they haven't been diagnosed with an airway disorder yet, that needs to also be looked into because that's the first thing you would treat when there's a combination, it
Correct.
sounds like.
Correct.
And then you can get rid of that airway piece, treating CPAP, orthodontically, whatever the issues are, then see how tired they still are and what needs to be fixed. Because it sounds like you have to sequence treatment.
Correct. Correct.
Wow. Okay. One of my questions for patients treated for sleep apnea who have excessive daytime sleepiness, when should clinicians suspect narcolepsy? So it sounds like after they feel they have a good treatment of the airway issue, if the patient
Airway and any other disruptors of night. So whether that's a movement disorder, whether that is an older gentleman, they wake up to go to the restroom all the time and they just say it's a prostate issue. Well, it's probably a sleep apnea issue, but maybe we need to get the prostate looked at and get urology involved. But these are the patients that you truly can say, I feel their nighttime sleep is good, quality, restorative sleep, but yet they're still having daytime symptoms. Also, question your fragmented sleep patients. These patients who you've done everything to help them, but they're like, I just can't stay asleep. I keep waking up and I can't stay asleep. So question those patients.
So if you had a few questions you would tell a dentist, orthodontist, myofunctional therapist to add to their questionnaire on initial patient intake that would help siphon out whether they need to refer for narcolepsy or to a sleep medicine doctor for that, what questions do you think would be good to add?
So I think it's more than just questions. So as a dentist, most patients will see a dentist more than they see the doctor, right? They go see a dentist for just maintenance. And so a dentist has a very unique perspective. They're at the entrance of the patient's airway. When you look into a patient's mouth, you're at the entrance of the patient's airway. So the questions per se should start with the dentist's assessment. Right? What are they visually seeing? Are they seeing erosion of the teeth? Are they seeing wearing down of the gums? Are they seeing high arched palate? Are they seeing tiny mandibles? Are they seeing, overbites that are happening? Are they seeing malocclusions, misalignments, enlarged tonsils? All those things should be posing red flags. Once the observation red flags happen, then the dentist should ask, do you have trouble falling asleep? Do you wake up often? Are you tired in the morning? Has anyone asked you if you snore or pause? Do you wake up gasping? Do you wake up with reflux symptoms? Is there, if they saw evidence of wear and tear in their teeth? Are you grinding? Are you waking up with jaw pain? These are all red flags that we may have an airway problem going on.
Right. But what about the questions they should add for narcolepsy? So they can
So
help refer for that.
really focusing on excessive sleepiness, fragmentation of the sleep. And then two, if they know that that patient they're seeing has already had sleep apnea treated and they're using their machine or they're using the dental appliance that they made and the patient's still complaining of, I'm tired, those should be questions we ask. Are you seeing the dark circles under their eyes? Talk to those patients of, hey, maybe we didn't find all of the problem and we may need to get back in.
Okay. And we know also narcolepsy is just one other sleep disorder, but there's a lot of non-anatomical, non-airway sleep problems going on, like periodic limb movement disorder, and seizures could be, other things that could be playing a role. So as a dental specialist in sleep medicine, orthodontist, myofunctional therapist, it's not all airway. And we have to remind ourselves of that because sometimes we get all excited about what we're seeing, and it's not always that. So I want to talk a little bit more about pediatrics and then finalize by talking about the treatment for narcolepsy so we can feel good thinking about treatments. For pediatrics, how does narcolepsy present differently in children versus adults?
So it's really due to pediatric patients can't just tell you, Mom, I'm so tired, right? You're going to see it in them. You're going to see it again when they choose to take a nap and not go play with their friends. You're going to see that they just don't have the stamina that they do with their peers. But they present a little bit differently as far as this is your patient who, as I said earlier, you're way past naps and all of a sudden they have a re-entrance of naps in their life and it's a function that has to happen or the kid can't keep going on. So when they start reintroducing naps as a necessity, start to question things. You also start seeing that they have this facial dynamic, this facial muscle movement that sometimes is considered a tic, but it's kind of their mouth starts doing something funny. It's not your typical cataplexy appearance as an adult, but again, they're not really picking up on it. So it's more of an open mouth phenomenon, a drooping eyelid, a little twitch or something that's going on. You start seeing behavioral issues. This is a good student who their grades are dropping. This is a good student who, never had any behavioral outbursts, hyperactivity issues because they're going into that compensation mode and they're a little more hyperactive. The teachers are calling and saying, I just don't know, they're taking naps and falling asleep during lessons. This is a change of behavior that just you don't have another understanding of why.
And should parents go to a pediatrician or go right to a sleep medicine doctor if they have that
So
ability?
I would say if your insurance allows it, you don't need a referral, go straight to the sleep doctor. But with that said, don't pass up your pediatrician. I mean, go to your pediatrician and let them know. But if you truly feel that something is wrong with your kid and pediatrician's kind of blowing it off, go straight to the sleep doctor. You have every right to do that. And most sleep specialists will still work with your insurance and work with your pediatricians to get those referrals needed for insurances if that's something that is needed.
And that's interesting too, that a child who might have narcolepsy may present as more ADHD hyperactive. Like you said, they might take naps and want to keep napping,
Yeah.
but ADHD can be confused oftentimes that you said poor sleep brain. So that's
Correct.
really a good thought for all of us to keep that in mind when we see these really hyperactive kids. So last thing I just want to go over is what is the treatment for narcolepsy? What are the management techniques or medication treatments or whatever is available?
So there's all sorts of things. So we have I don't want to ever want to say it's a great time to be in the field of sleep medicine and narcolepsy, but it is because we finally have many options. But before we get to pharmaceutical, let's talk about what are some natural, non-pharmaceutical things that can be done. When you're dealing with a narcolepsy patient, strict sleep-wake cycle, okay? So we talked about earlier as narcolepsy is a disorganization of your sleep and wake. So if you're going to sleep till 2, 3, 4 p.m. and then want to go to bed at 8, your brain is not understanding when it's supposed to be awake or asleep. And when I tell patients this early on, they're like, but you don't understand. I can't stay awake, and now you're asking me to stay awake? Like, this doesn't make any sense. So as best you can, stick to a strict, I'm going to go to bed at 10 and I'm going to wake up at 8. I'm not asking you to wake up at the crack of dawn, but let's stick to a normal, go to sleep when it's dark, wake up when the light comes out. And then if you need, strategically place a nap during the day. And I'm not talking a 4-hour nap. I'm saying set an alarm. I have one patient that their nap is 12 minutes, not 15, not 10. It's 12 because he knows that's his mark that he needs. So strategically place a nap, and your sleep doctor should be able to work with employers and things like that to help this get arranged for you. So strategically placing naps. Clean eating. This is a big one for all health. Clean eating. Get the toxins out of your body. Do some gut detoxing. Hydration. Water hydration is key. Exercise. Healthy exercise. Whenever you get sleepy, sitting at your desk, walk up, get up, go make a little lap and come back. And then 2, when we exercise, it sends those endorphins. Those endorphins are those feel goods. Those endorphins run our dopamine. Dopamine is one of our wake centers. So again, these are not going to cure it, but these are ways to help you cope. Okay. And then that goes into what can we do on the pharmaceutical front? Well, there's old school stimulants, there's new age stimulants, there's what we call wake promoting agents that they're not stimulants, but they help you wake up during the day. Then there's some that work on the histamine that helps us wake up during the day. There's some that what I describe to my patients is it decreases your sleep drive and increases your wake drive. It stimulates you awake. So you have your stimulants, and then you have I'm going to just make your wake drive feel a little bit more than your sleep drive, so therefore you feel more awake. But then we have a very unique class of medication that actually you take it at nighttime, and it alters the way you sleep. Therefore, you feel different during the day. So it gives you a more slow wave restorative sleep and alters and fixes that disrupted nighttime sleep dynamic to where you feel more awake and functioning during the day. So there's all sorts of medications. There's no one better than the other for the particular patient. You just really have to work with your patient, see what are their true, symptoms that they're having, what medications fit with their lifestyle, and just work individually with the patient to develop their unique treatment protocol.
Do any of the medications positively impact the cataplexy factor, or will that never go away?
Yes, so a lot of them do. You have wake-promoting agents, non-stimulants, but you have wake-promoting agents that can affect the cataplexy, as well as your nighttime symptoms affect you. Your nighttime medications will improve your cataplexy as well.
Okay, I didn't realize that muscle
Yeah.
paralysis can actually be impacted.
And there's also old school antidepressants that we actually use in narcolepsy patients for the cataplexy.
Interesting. And then last thought that just came to mind kind of throughout this talk is, does this ever get confused with like a circadian rhythm disorder?
It does. And again, that's really getting down to the history of how your patient is presenting, because you can have sleep state misperception a lot, that our patients are like, I'm never sleeping. And then we sleep study them, like, yeah, you are sleeping. Or you have patients that they're like, I'm sleeping all the time, but it's just these little bitty brief things. And so there's a sleep state misperception. And then, yes, as I talked earlier, we need to learn your body clock, because we all are on a slightly different circadian rhythm. So we have to understand what the patient is truly experiencing and what is their innate body system that we're dealing with.
And if you had circadian rhythm disorder, you're not going to have cataplexy. You can correct me if I'm wrong, but you're probably not going to have the sleep paralysis often, or the hypnagogic.
So it's really good history taking.
Okay. Hypnagogic, right? Am I saying them correctly? I'll never forget what they stand for, but I'm like, I have to say that. Okay, that was just so informative for so many reasons. Patients we treat, our airway patients, that comorbidity factor, and just knowing there's so much to sleep, and unfortunately so much that could go wrong. And when we don't sleep well, everything gets impacted.
Everything is impacted. And when you truly look at 16 hours of our day, we're supposed to be awake, and 8 hours of our night, we're supposed to be asleep. That's a lot of our life. And so if we're not getting good quality sleep, see how it can affect the rest of your life. It's relationships, it's profession, it's family, it's social, it's just the ability to accomplish something in life. And it's your own personal, how do you feel about yourself if you can never get out of bed and you can't accomplish anything? So sleep really affects everything.
Yes, and I really appreciate your office and how you work with the patients with such a caring attitude. Obviously, everyone I'm sure can feel your love just hearing you speak. And it's just, you're so great to work with. So you're from the Comprehensive Sleep Medicine Associates, which is in Texas. I know you do telemedicine
Right.
appointments
We
because
see
a lot,
patients around the world in other countries, and that we do telemed as well.
which is amazing. Patients fly into your office because they know they're getting the best care. So I really appreciate all the information you presented to us and just so much more that I've learned today. So thank you so much for being here and taking time to educate all of us.
Absolutely. Thank you for having me. As you said, this is my passion. I love helping patients and family members in any way that I can. So when you have a hypersomnia patient or a sleep patient in general, the family is affected too. And so if I can help in any dynamic through education, treatment, assessing, spreading awareness, that's what it's all about.
For sure. And in the end of April, the Sleep
Mhm.
Education Consortium is going on. Will you be speaking on
I
narcolepsy
will
this
be
year?
speaking again, correct?
Great.
Mhm.
Love
Mhm.
that. So that will be amazing. If anybody's more interested in not just narcolepsy, but all the airway facets, Dr. Simmons has a nonprofit. It's called the Sleep Education Consortium, and Maggie Lavender speaks there every year. I'll be speaking this year as well. And that
Yay!
is the end of April, and it's a 2 to 3 day, depending on whether you're medical
Yeah,
only
it's
or
a very unique conference because it's where we get dental and medical all together in one room, and we're looking at the whole comprehensive, multidynamic, multidisciplinary approach to a sleep patient.
exactly. And it's so important for our practitioners to know that it's not just airway
Right.
and to learn about the other aspects of sleep. And we
Mhm.
cover airway and all different treatments, but also other components to sleep, including periodic limb movement disorder, restless leg syndrome, narcolepsy, REM behavior disorder, all these other things that it's important for us all to open our eyes to see these other aspects. So again, Meg, thank you so much. I look forward to talking to you soon.
Absolutely. Have a wonderful time.
Thank you.
You
Bye.
too. Bye.
Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.